Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's February 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article describing an observational population-based study of 2,800 patients with incident atrial fibrillation but not dementia to assess the effect of warfarin anticoagulation and the time in therapeutic range for warfarin therapy on the risk of dementia. The article is authored by Dr. Malini Madhavan and colleagues from Mayo Clinic in Rochester, Minnesota, and the University of California in Los Angeles. The study included records retrieved from the records linkage system of the Rochester Epidemiology Project between January 1, 2000 through December 31, 2010. This study presents the first comprehensive longitudinal study on the risk of dementia in patients with atrial fibrillation, with and without oral anticoagulation, in a community setting. Dementia was diagnosed in 12.8% of patients 6 months or more after the diagnosis of atrial fibrillation and over a mean follow-up of 5 years. After adjusting for confounders, warfarin therapy was associated with a reduced incidence of dementia with an estimated 20% reduction in the risk for dementia. Only those patients in the 2 highest quartiles of time in the therapeutic range were associated with a lower risk of dementia. A 10% increase in the time in the therapeutic range with a 10% reduction in time spent in the subtherapeutic and supratherapeutic ranges were associated with a decreased risk of dementia. The authors noted that patients prescribed warfarin tended to have more comorbidities than those not prescribed warfarin, many of which have been known to affect the risk of dementia. Although statistical methods adjusting for these confounders were undertaken, the authors do not rule out the possibility of residual confounders, thereby resulting in a more conservative estimate of the association between warfarin use and dementia. The authors conclude that oral anticoagulation with warfarin was associated with a reduced risk of dementia in a community-based cohort of incident atrial fibrillation, with a more prominent effect noted in those with CHADS VAS score of 2 or greater. These data support and extend the potential benefits of current recommendations for anticoagulating high-risk patients with atrial fibrillation. Furthermore, the authors note that in patients taking warfarin, more time in the narrow therapeutic window of warfarin was associated with a reduced risk of dementia compared with patients with less time in the therapeutic range. This article is accompanied by an editorial authored by Celine Gallagher and colleagues from the Center for Heart Rhythm Disorders, South Australian Health and Medical Research Institute, University of Adelaide in South Australia, Australia. The editorialists comment that the work of Madhavan et al. Make a significant contribution to our understanding of the role of anticoagulation in reducing the risk of dementia and atrial fibrillation. They further point out that atrial fibrillation may be associated with both reduced brain volume and impaired memory, independent of cerebral infarction. Thus, it's quite plausible, given the association between atrial fibrillation and stroke, that repetitive microemboli may underlie the association between atrial fibrillation and dementia. They also emphasize the need for additional studies of the cerebral effect of the hypocoagulable state associated with atrial fibrillation to guide future novel therapies. Our first highlight article is an original article that evaluated the use of intravenous bevacizumab in patients with hereditary hemorrhagic telangiectasia, also known as Rondeau-Osler-Weber syndrome. This autosomal dominant disorder leads to arteriovenous malformations in multiple organ systems. It is authored by Dr. Vivek Iyer and colleagues from Mayo Clinic in Rochester, Minnesota, and in Scottsdale, Arizona. Arteriovenous malformations in the nasal cavity and gastrointestinal tract may lead to recurrent epistaxis and GI bleeding. Epistaxis is a cardinal manifestation affecting 50% of patients by age 20 and virtually all patients by age 50. Therapeutic options are limited and rarely result in a durable response. Bevacizumab is a monoclonal antibody that binds to circulating vascular endothelial growth factor, VEGF. Binding of VEGF to its receptors generally triggers a pro-angiogenic cascade with the recruitment and proliferation of endothelial cells and the attendant development of new blood vessels. The study included 34 patients with a median age of 63 years at the time of intravenous bevacizumab initiation. Epistaxis severity scores and the quality of life data collected during and after the initial treatment cycle were compared with baseline. At 1 month after initiation of bevacizumab, epistaxis severity scores were significantly decreased, and the improvement was maintained following completion of the initial treatment cycle. At the time of the report, 3 patients were still receiving bevacizumab based on the initial protocol. Of the remaining 31 patients who had completed the initial dosing cycle, the median duration of follow-up was 13.6 months. A total of 18 patients have required at least one top-up of IV bevacizumab because of worsening bleeding and/or anemia after the initial treatment cycle. The study showed an improved overall quality of life after treatment with bevacizumab. Bevacizumab significantly decreased the degree to which epistaxis interfered with the quality of life, and most patients were able to return to normal activities previously avoided for fear of precipitating a nosebleed. The authors conclude that bevacizumab provides excellent short-term and long-term efficacy with an acceptable safety profile. They suggest that systemic bevacizumab be considered as a first-line therapy for the treatment of refractory bleeding in patients with hereditary hemorrhagic telangiectasia. The second highlight article is an original article that examined the rate of decline of kidney function, end-stage kidney disease, and mortality in patients with common glomerulopathies. It is authored by Dr. John Sim and colleagues from Kaiser Permanente Medical Centers in Southern California, Los Angeles, Pasadena, and San Francisco, California. The authors retrospectively identified a cohort of Kaiser Permanente Southern California members who were enrolled in the prepaid integrated healthcare system, which provides comprehensive care to more than 4.2 million members in Southern California. The authors identified individuals who underwent a native kidney biopsy between January 1, 2000 and December 31, 2011, and analyzed outcomes in 2,350 such patients. The glomerulopathies included were focal segmental glomerulosclerosis, membranous glomerulopathy, IgA nephropathy, lupus nephritis, and minimal change disease. The primary outcome was incident end-stage renal disease with mortality as a competing outcome during the follow-up. Over a mean follow-up of 4.5 years, 21.2% of patients progressed to end-stage renal disease, and 8.3% of patients died prior to incident end-stage renal disease among the study cohort. The authors observed considerable differences in outcomes among the 5 different glomerulopathies. Focal segmental glomerulosclerosis, the most common glomerulopathy in this study, exhibited the largest annual decline in kidney function and the highest incident rates for end-stage kidney disease, as has been observed in some prior studies. The importance of the study by Sim et al. Is at least fourfold. First, it reflects an analysis of outcomes in glomerulopathies in a large, diverse patient population managed in the community hospitals and clinics of an integrated health system, not in tertiary centers, where such analyses may more likely include patients with more refractory disease or patients with therapy-related side effects. Second, it demonstrates the heterogeneous outcomes in common glomerulopathies. Third, it underscores the risk for end-stage renal disease in focal segmental glomerulosclerosis. And fourth, it offers prognostic information regarding these glomerulopathies. The third highlight is a concise review article that analyzes recently published literature regarding several of the emerging concerns regarding possible adverse effects arising from long-term use of proton pump inhibitors, and whether such concerns may alter prescribing practices. It is authored by Dr. Avinash Nira and colleagues from Mayo Clinic in Rochester, Minnesota. Proton pump inhibitors are among the most widely utilized medications worldwide, both in the ambulatory and inpatient clinical setting. Proton pump inhibitors are currently approved by the U.S. Food and Drug Administration for the management of a variety of gastrointestinal disorders, including symptomatic peptic ulcer disease, gastroesophageal reflux disease, and non-ulcer dyspepsia, as well as for the prevention of gastrointestinal bleeding in patients receiving antiplatelet therapy. The authors examined associations that are likely causative, including hypomagnesemia, vitamin B12 deficiency, and small intestine bacterial overgrowth. Associations that are not clear, such as bone fractures, Clostridium difficile infection, acute and chronic kidney disease, and dementia. And associations that are unlikely to be causative, such as community-acquired pneumonia. The majority of the data are derived from retrospective observational studies which have inherent biases, risks for confounding variables, and the inability to determine a definite causal relationship. Most studies report mild to moderate overall associations with relative risks of 1 to 2 between proton pump inhibitor use and the risk of bone fracture, Clostridium difficile infection, pneumonia, vitamin and mineral deficiencies, kidney disease, and dementia. Thus, because many of these adverse effects are relatively uncommon, the absolute risk to patients remains quite small. Reading this article and completing the appropriate documentation offer up to 1 hour of continuing medical education credit in conjunction with this article. As always, you can access these highlights and editor's choice articles free of charge during the entire month of February when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You will find other free content such as our Pioneers and Legends in Medicine video interviews, the Path to Patient image quiz, Art at Mayo Clinic, stamp vignettes on medical science, and interesting medical images. You can also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel where you'll find videos of full author interviews, our 60-second video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which is available from our website on the home page, as well as through iTunes. And, as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.